Hi everyone, my name is Jasmine Arnold and I will be presenting on esophageal cancer and malnutrition. Let's get started. My case study began on September 9th through September 20th. The next topics will be the information discussed: esophageal cancer, malnutrition using Aspen guidelines and refeeding syndrome. We'll review TPN, enteral feeding recommendations, the nutritional care process, treatment process, and prognosis. So esophageal cancer, there's two types: esophageal squamous cell carcinoma and esophageal adenocarcinoma. For the first one, esophageal squamous cell, it is more common worldwide, whereas esophageal adenocarcinoma is seen more in developing countries. In the US, it's 7th leading cause of death in males. And in 2018, approximately 17,200 new cases were reported and 15,800 deaths, although only 28% were accounted in the national registry. The etiology is causes unknown, but some causes can be because of Barrett's esophagus, precancerous cell changes in the esophagus, gastroesophageal reflux disease like GERD, obesity, tobacco use, and consumption of alcohol. And here is the clinical case study I will be discussing. Mr. G is a 66-year-old African-American male whose present illness is stage 4 metastatic esophageal cancer, which has spread to bone. He was admitted to the hospital on September 7th with persistent tachycardia and back pain. He had a recent opioid overdose in mid-August 2021. He has ongoing dysphagia. He was a former smoker and alcohol user, 1 pack a day for 30 years and 21 beers per week. He received chemotherapy and radiation in 2019, and he now has a recurring cancer. His medical history, a little bit more. He has chronic respiratory failure, severe spinal canal stenosis, diabetes mellitus type 2, major depressive disorder and anxiety, chronic pancreatitis, and as mentioned earlier, the dysphagia. His anthropometers are: he is 5 feet 9 inches tall. His weight is 97 pounds. His body mass index is 14.3. Indicates that he is underweight. His usual body weight is 114 pounds, which was about a month ago. And he has severe weight loss of 17 pounds, which is 15% in 1 month. And here you can see the calculation on how we found out how much the weight loss was, 15%. Pertinent medications, he is taking Colace, Senna, fat emulsion, 20% infusion of 250 mLs, and that is for his TPN line, which we'll discuss further in the next slides, regular insulin, and also Megace. For his nutrition assessment, he met the Aspen criteria for malnutrition. So you need to have more to diagnose severe. So he had more than 2 actually. He had severe protein calorie malnutrition. It was severe and chronic illness. His weight loss greater than 5% in 1 month. So he had 15% loss in 1 month. His energy intake was less than or equal to 50% energy intake compared to estimated needs for greater than or equal to 1 month. And his body fat, he had severe depletion in the occipital and the arms. And muscle mass, he also had severe depletion in the temporal and the clavicle. Mr. G also reported low appetite, eating only applesauce for the past month to take medications, and unintentional weight loss. The picture to the right is not Mr. G. It is a picture of an example of a person that has similar criteria for malnutrition. As you can see, the wasting on the temporals as the silhouette of this man on the picture. His eyes, below the eyes, it looks very deep. The next topic we will cover is refeeding syndrome. Because Mr. G stated that he was not eating much for the past month, he is at risk of refeeding syndrome. And this is a condition characterized by metabolic, electrolyte, and fluid shifts, such as hypophosphatemia, that occurs in malnourished patients when they begin refeeding carbohydrates after a prolonged period of anorexia that can develop when introducing foods by orally, enterally, or parentally. So it's important to start feeding slowly to prevent refeeding syndrome. And here's a hint for one of the questions. It's important to monitor daily the potassium, phosphorus, and magnesium. So the question I want you guys to think about is, what 3 electrolytes should be monitored daily for a patient at risk for refeeding syndrome? Hint, hint. In extreme cases, this can lead to cardiac, respiratory, and neurologic disturbances or even death. Next, we will look over some nutritional impacts of cancer. One of the most common ones will be the cancer cachexia. Some key characteristics include progressive weight loss, anorexia, immunosuppression, altered basal metabolic rate, generalized wasting and weakness, abnormalities with fluid and energy metabolism. So metabolic changes. So it creates a shift in energy metabolism, which causes the patient to lose muscle tissue and decrease energy utilization, which patient is an increased need for protein and calories. Other side effects will be nausea, vomiting, diarrhea, constipation, fatigue, altered taste or smell, and dry mouth. Here you can see the PS statement that I created. Malnutrition related to body fat, severe depletion, occipital and arm, and muscle mass, severe depletion, temporal and clavicle, as evidenced by 15-pound weight loss within 1 month. And this is my recommendation from September 9th. First one is the IV thiamine replacement, 100 milligrams, QD for 10 days, first dose prior to the tube feeding initiation, 1 milligram of folate for 10 days, and a multivitamin with mineral, QD, high risk for refeeding. And then post-PEG placement, I recommended a carb-controlled tube feeding formula, given his history of diabetes. And here's the recommendation. The tube feeding is Diabetosaurus AC at 65 mLs per hour. Initiate 25 mLs per hour, advance 10 mLs every 12 hours to goal. The water flushes per MD or 100 mLs Q or every 6 hours. This will provide 1,716 kcals, 86 grams of protein, a total of 1572 mLs of free water, and it will meet the recommended daily intakes. And of course, we want to daily monitoring of the potassium, phosphorus, and magnesium. Interventions, we want to monitor the tube feeding tolerance, the labs, intake outputs, medication, weight loss, and of course the potential risk for refeeding, and also collaborate care with the interdisciplinary team. Although my recommendations were provided on the 9th, Mr. G was not able to eat by mouth and was evaluated. And these recommendations are from another dietitian. And they were not able to scope as he had a large mass in his throat. So the TPN was recommended. And this is the recommendation from the RD that was available on the weekend. And the doctor ordered a peripheral inserted central catheter or a PICC line prior to initiating this recommendation. And she recommended dextrose 15%, amino acids 4.5, lipids at 20, administered 3 times a week. The rate was 70 mLs per hour for 24 hours, and the glucose infusion rate is 3.97. It provided 1373 kcal, 76 grams of protein, and this is equivalent to 80% of the nutrition goals. To the right, I did all the calculations to show how she got to the 1373. So the amino acids, the top is what we used the current weight, so 97 pounds, 44 kcals. And this is we kind of wanted him to be at 35 to 40 and at 1.8 to 2 of protein. And here is the calculation for the amino acids, lipids, and the dextrose. It's important that because of the PICC line placement, she was able to recommend up to 15% of dextrose, but it's important for her to stay below that amount because the patient did have a history of diabetes. Here's a calculation for the glucose infusion rate. So from this calculation, it came up to 3.97. It is important to stay below the 5 milligrams of carbohydrates per kilogram per minute to prevent excessive administration of carbohydrates and complications, such as hyperglycemia, liver abnormalities, and increased carbon dioxide production. So here is another question, and I put a hint to, it's important to stay 5 or below. So true or false, a glucose infusion rate of 6 milligrams of carbohydrates per kilogram per minute is considered an excessive amount for carbohydrates. Because the patient was not able to eat by mouth, they temporarily recommended the TPN. Then on September 14th, he was given a surgical PEG. And then on the 16th, I was able to see him. And this is my updated recommendation. I decided to go with the same formula. I just decreased the amount to advance the rate because we want to make sure we start off slow. And again, the carb control tube feeding was given because of the history of the diabetes. And then at this point, his blood glucose levels were they increased up to 200. And here's that recommendation. It was important to titrate the TPN down as the tube feeding titrated to goal. So as he's tolerating the tube feeding, we're slowly gonna wean him off the TPN. I also recommended that we discontinue the megas since he's not eating orally. He doesn't need that oral gut stimulation. And then with the insulin that he's on, they're definitely helping with the blood glucose max to hopefully stay between 140 to 180. And here is the highlights of that recommendation and how I came up with all my numbers. Again, the diabetic source provided 1.2 kcal per ml. And this gave us, and I wanted to get to the 1716 kcals. I divided that by 1.2 and I got 1430 mLs. To calculate the rate, I divided the amount of mLs by 22 hours. And that is what this hospital uses, and not 24. For the protein, this is how I calculated the 1430 divided by 1,000. I got the 1.43, and then 60 grams is what the formula Diabetic Source provides. Multiply that, and I was able to get 86 grams of protein. And the free water calculation, for that one, I estimated 35 mLs per kilogram. Usually it's about 1 ml per calorie. And then to meet the RDI, the volume, to get that calculation, I did the volume of the tube feeding divided by the DRI of 1250. So 1430 mLs divided by 1250 gave me 1.14. So 114%, which is above 100. So this does meet the recommended. Here are some of the labs that came back a little bit abnormal. For these, what I want you to focus on is on the dates. Up on the top and then towards the bottom, you can see when different tube feedings or the TPN began. In the beginning, the glucose was good because the patient wasn't being fed, so it could be falsely low. And then once you started the TPN, it started increasing. Initially, the doctor that placed the peg recommended fiber source. It was actually, and then we transitioned over to the diabetic source to help them with the stabilizing the glucose levels. The red on the hemoglobin was also low, so this could be normal amounts would be 13.5 to 17.6 grams per deciliter. This could be because of the cancer therapy or the radiation, or simply just not eating enough, so possibly deficiency in thiamine or folate. And with the refeeding syndrome, again, we want to monitor those electrolytes. At one point, it did go slightly low for the phosphorus, but then after that, it was okay. So, which was good. BUN, normal levels would be 9 to 23 milligrams per deciliter. And then they started increasing. And this could be indicative of possibly dehydration, renal failure, shock, or stress. And this next section, we'll talk about monitor and evaluation. So number one would be adequate nutrition to promote healing, maintain weight, and preserve lean body mass. And the second one would be tolerance of the tube feeding alcohol rate. Prognosis. So Mr. G does have a poor prognosis as cancer has spread to the bone, creating pain on the spinal cord, compression, and new nodules in lungs. The low appetite and large osseous mass in throat causing dysphagia, evidence of malnutrition and wasting, the chemotherapy and radiation that happened in 2019 is now, the cancer is recurring. And palliative care began on September 28. And sadly, Mr. G lost his battle to cancer on September 20th. And this concludes my presentation. And here are a couple of my references.